So much for the invitation. Good evening. I will start with a case very quickly. This is a patient, 81-year-old, with symptomatic severe aortic stenosis, as shown low flow, low gradient, which is also seen in a coronary calcium score of more than 3,000, which was confirmed. The patient has prostate CA and he's on chemotherapy and or hormonal therapy and permanent pacemaker, so we don't have to worry about a pacemaker implantation in this case. But also has coronary artery disease, and just a month before the procedure, he underwent a PCI of the proximal RCA stenosis. So first of all, here's the echo of this patient, good LV function. You see the aortic valve, which is not opening very well. It's not severely calcified, as you can see. And this is the Vmax of the aortic valve, which is 3.6 millimeter from the suprasternal view, 3.4 from the standard 4-chamber view. So, should this patient have a TAVI or a surgery? He's 81 years old. I think TAVI is the default procedure in this patient. As we always do, we do the CT scan of with the TAVI protocol, and you see that there is a bicuspid aortic valve with a raphe between the left and the right coronary cusp. It's not severe calcification, very much protrusion of the raphe. It's a moderate calcification of the raphe and the aortic valve leaflets. So the question is, when you have a bicuspid valve, should this patient go for a TAVI procedure? Is there any very high risk characteristics for a TAVI procedure, which is a severe calcification of the aortic valve, of the raphe, and the intracommissural space? So the answer in this patient is no, there is no severe calcification. So TAVI procedure should be a non-very high risk for aortic root rupture or malposition of the TAVI valve because of the underexpansion due to severe calcification. So we aim to proceed with the TAVI procedure. But as you see here in the CT scan, you see the chunk of calcium extending from the annulus of the aortic valve down to the LVOT, as you can see here, which is pretty much severe. And here is the raphe and the moderate calcification. So what's the implication of this chunk of calcium to the LVOT? It has to do with the selection of the valve, because the next step when you have a bicuspid aortic valve, once you exclude the high risk characteristics for a severe complication, is the valve selection. And in this case, with a big anatomy, as you see here, the anatomy is big, the sinus, the annulus is big, 27.8, and the sinus of Valsalva are wide. So they can accommodate a large valve, and the risk of obstruction, of the coronary obstruction, is very low. And as you can see, the patient has coronary artery stenosis, so sometime in the future may need a catheterization. So have big sinus of Valsalva can accommodate a big valve. But the LVOT is not very big, so it's around 24 millimeters. So if we put a self-expandable valve in this case, which would be 26 or 29, depending on the additional measurements, you have to smash the coronary calcium in the LVOT, which is relatively narrow, 24 millimeter, and you would have maybe a rupture at this point of the calcium. So that's the reason why we choose the self-expandable valve and not the balloon expandable valve. And the next question is, what's the valve sizing in these patients with bicuspid aortic valve? Should we go with the annular sizing or intercommissural sizing, which is the size of the commissures, between the commissures, 4 millimeter or 6 millimeter above the aortic annulus? Here, at 4 millimeter, the intercommissural distance is 25.6 and 6 millimeters, 26.2 millimeter. So we pretty much once we use the self-expandable valve, which is a large valve, 20 Evolut 34, if we go by the aortic annulus plane, it should be 34 millimeter. If we go by intercommissural diameter, it's again above 26 millimeter, so we'll go again with the same valve, with a large valve, 34 millimeter. There are two other methods of measuring the size of the valve that you're going to put there, and this is the LIRA measurement. So it's the measurement, the level of implantation at the raphe, which is measuring at the point of the most severe calcification of the raphe and the aortic leaflets. You measure the perimeter and you derive the diameter according to the perimeter you measure at this point. And usually it's one size below the measurement you do by the aortic annulus. Measurement by aortic annulus is good for 85% of the cases. Measurements for the LIRA method is good for 15% of the case of the bicuspid aortic valves. So we go with a big valve. We have a good diameters of the peripheral arteries. And one more thing to remember, when you have a bicuspid valve, when you use the self-expandable valve, you go with a cusp overlap view as an implantation view. When you use the balloon expandable valves, we go with a coplanar view, which is a three-cusp view. So in this case, in our case, we go with a cusp overlap view as an implantation view, which is this view here, non-coronary cusp on the left side, and the two other cusps, right and left, on the other side, on the right side. This is the aortogram. This is the gradient. As I mentioned before, it's a low flow, low gradient aortic valve stenosis. We have 20 millimeter of gradient to begin with. And here's the LV gram. It's a good size ventricle. This is the balloon. What's the diameter of the balloon? It's 23 millimeter, which is just below the small diameter of the annulus, or the LVOT. The LVOT has a severe calcification, as I mentioned before, so we go here with the smallest diameter of the LVOT, which is 23.5, so we chose a 23 millimeter balloon. This is the first attempt to expand the valve, the position of the valve. The valve in the first two times it popped out, so we resheath it, and this is the third attempt, which we managed to keep it in place in the cusp overlap view here. Here we take off the parallax to see where exactly is the compared to the left coronary cusp, which is at a 0 point, as you see here. Here is the cusp overlap view with a left cusp opposing the other two on the right side. Here's the left, and here are the other two cusps. So it's maybe -1 millimeter or -2 millimeter. We know as we release the valve, this will come down a little bit. So we'll go back to the initial cusp overlap view, and we release the valve, which was self-centered. And here is the final aortography. You see very minimal aortic regurgitation, a good position at 0 level, almost 0 level, and a gradient of from 20 to 3 millimeter of mercury, and a good peripheral sealing. Here's the next day echo showed a very minimal aortic regurgitation with a gradient with a Vmax of 2.7, a good LV function. The pacemaker is taking over, and a very nice circular aortic valve prosthesis. 1 month later, we have a gradient, a Vmax of aortic valve 1.5, as you can see here, and the same minimal trace AR with good LV function, nice valve, and back on sinus rhythm. Thank you very much.
Thank you very much. Very nice case. Any comments? The moderators?
Yes. Can I speak?
Yes.
Yes. Excellent presentation, excellent case, Dr. Pilatis. Very difficult one with this sclerotic calcium in the LVOT. And one thing that I want to mention is that you have done very well to choose a self-expandable valve and not a balloon expandable. But it's another thing. As you have told us, the day after the procedure, the velocity of the maximum velocity of the aorta was 2.7, and 1 month later it was 1.4, if I remember well. This is a very common finding, because at the beginning, after the release of the stenotic aortic valve, the good working of the left ventricle to try finds a velocity of elevates the velocity of the aortic valve, and in about 1 month or 3 months, everything is going to be normal, with a normal flow, with a normal diastolic function of the left run of the left ventricle, from the moment that the sclerotic aortic valve is off now. This is to remember that after the surgery after the implantation, it is not uncommon to find big velocities after, and to normalize these velocities after a month or 2.
You're very right. Thank you for the comment.
Okay. Thank you very much. So last but not least,